Hello and welcome. My name is Mackenzie Block and I'm the project specialist here at HCNJ. I've been working with Charles for over 2 years, providing special trainings to New Jersey facilities across the state. We've had the opportunity to reach many communities through these trainings and are continuing to do so for our members of the association. Charles Arobis is HCNJ's Director of Quality, Clinical, and Regulatory Services. Today, Charles and I have prepared a very informative training for you. The purpose of this training is to discuss the QSO memo from CMS 2413. The objective of this training is to review the critical elements of these requirements and to ensure that facilities will be in compliance with these new requirements. Today, Charles will be reviewing Regulation 48371, Facility Assessment. The purpose of 48371 is to determine what resources are necessary to care for residents during day-to-day operations, including nights and weekends and emergencies. Note that everything you see in red text are the new additions to the existing regulations. The date this regulation was issued on was on June 18th, 2024, and the effective implementation date will be August 8th, 2024. And now I'll be turning it over to Charles.
Thank you, Mac, and welcome everyone. I'm Charles Larobis, Director of Quality, Clinical and Regulatory Services at HCNJ. This training will provide an overview of the recently released QSO memo and highlight the key components required under the regulation. It will help you plan, prepare, and conduct the facility assessment before the effective implementation date. At the end of the presentation are links to several resources from the American Healthcare Association with granular details for compliance. The third link is the QSO memo, where you can find an advanced copy of the revised regulation. The slides will discuss 3 sections. First, facility assessment. Second, facility resources. And third, the facility-based and community-based risk assessment. It is helpful to click on the links to the resources listed on the last slide, mainly AHCA's action brief, and utilize the facility assessment checklist, which covers the essential requirements. Take note that surveyors should not evaluate the quality of the assessment, but on the basis whether the facility assessment contains the required components of the required regulation. So let's begin. What is it about? It is the expanded facility-wide assessment required in the minimum staffing rule. It is the first provision, part and parcel of the staffing mandate to come into play. It codifies requirements to use evidence-based strategies. It highlights the need to include behavioral health and outlines who should be involved in the assessment process. By August 8th, the new facility assessment must be completed. I would anticipate that surveys will focus on this as this is tied to the minimum staffing standards as mentioned. Next slide. Let's look at the federal requirements. The facility assessment should address the resident population, the number of residents, and the facility's resident capacity. The care that is required by the resident population using evidence-based, data-driven methods, considering behavioral needs consistent with individual resident assessments. It includes staff competencies and skill set necessary to provide care. Next slide. It should address the facility resources, which include services provided such as physical therapy, pharmacy, behavioral health, and other rehabilitation therapies. It includes all personnel, including managers, nursing and other direct care staff, those under contract, and volunteers, as well as their necessary education and training and competencies. Third, the facility-based community risk assessment utilizing an all-hazard approach, which we'll discuss in a later slide. Next slide. The facility resources. Looking at the elements of the QSO, on May 10, CMS published a new regulation under 483.71, which was previously 483.70, as part of the minimum staffing standards for long-term care facilities. The new requirements specify that facility assessment must include the evaluation of diseases, conditions, physical or cognitive limitations, various acuity levels, and other pertinent information about the resident population. The other pertinent information refers to the social determinants of health and equitable access to care of the resident population. Next slide. So the assessment should drive staffing decisions, inform the facility what skills and competencies are required to deliver care, and it should contribute to identifying additional needs for residents, such as physical space, assisted technology, individual communication devices. And you must ensure active involvement from key individuals, mainly facility leadership and management, direct care staff, and you must solicit input from resident and families, which we will discuss further. Next slide. So the Appendix PP of the State Operations Manual has been updated that reflects the regulatory requirements released. Note, while facilities may be in substantial compliance with the requirement at 48371, if surveyors find that resident needs are not being met due to insufficient staffing, the facility will be cited for non-compliance at 483.35 and be required to implement a plan of correction. So that refers to nursing services, and the tag for that is F725. Next slide. So the facility must conduct facility-wide assessment to determine what resources are necessary to care for the residents competently, as mentioned, both day-to-day operations, including nights and weekends, and emergencies. The facility must review and update the assessment as necessary and at minimum annually. The facility will also review and update the assessment whenever there is a substantial change to the plan as part of the assessment. We will discuss the last two bullets in the later slides that talks about changes to its resident population, new diagnoses, and new treatments being provided. Next slide, Matt. So let's look at 48371. So those in red fonts are the new language that's utilized in this mandate, was discussed in the previous slides. It includes physical environment, equipment services, and other physical plant considerations. Any ethnic, cultural, or religious factors. It's not limited to activities, food, and nutrition services. Next slide. So the facility resources includes all buildings and other physical structures, all equipments, both medical and non-medical, services provided such as behavioral health, and inclusion of all personnel, including managers, nursing, and other direct care staff, those under contract and volunteers. And again, highlight on the necessary education, training, and competencies to deliver care. The inclusion of health information technology resources, which should include your downtime protocol and the safe transfer of data. Next slide. So facility-based community assessment should utilize all hazard approach as required in 483.73, which refers to the facility's ability to maintain continuity of operations, required supplies and resources during emergency and natural disaster. For an example of this would be if a facility is located in a flood zone and how the facility manages that. Identify potential loss scenarios and collaborating with local or county Office of Emergency Management. The facility's emergency preparedness plan should be integrated and consistent with the facility assessment. Next slide. So who should be involved in the process? At minimum, nursing home leadership and management, the governing body, medical director, the administrator, director of nursing. It includes direct care staff, RNs, LPNs, nursing assistants, and representatives of the direct care staff. And lastly, it should solicit and consider input received from residents, representatives, and family members. Next slide. There are a variety of ways to solicit input. One, by distribution of questionnaire related to staffing, placing convenient suggestion boxes throughout the facility, and providing annual notices for soliciting input prior to the annual review and update. Next slide. More on the regulation. So the assessment should inform staffing decisions to ensure that there are sufficient number of staff with the appropriate competencies and skill sets to deliver care. You must consider specific staffing needs for each resident unit in a facility and adjust the care and the assessment as the population changes. Consider specific staffing needs for each shift, such as day, evening, and nights, and based on its resident population. Develop and maintain a plan to maximize recruitment and retention. So this speaks about your workforce development strategies. Include contingency planning for events that do not require activation of the facility's emergency plan, but has the potential to impact resident care. Next slide. So switching gears, let's look at ACA's tips before you begin facility assessment. First, determine who will be a part of the facility assessment team. Definitely include those required per regulation. It is very helpful to include other department managers not listed in the regulations, such as listed on the slide, but not limited to what's on the list, such as the dietary manager, missions coordinator, MDS coordinator, business office manager, etc. Next slide. You must solicit input from other direct staff, from physicians, nurse practitioners, physician assistants, and determine how you plan to engage resident representatives and families. You can do this through resident council meetings and family council meetings. It's helpful to schedule an initial meeting to discuss the purpose of the facility assessment and what information you need from members. Next slide. Ask members to prepare evidence-based data to present to the group, such as the admissions department collecting the number of admissions, both weekdays and weekends, and diagnoses frequently admitted, average daily census. The MDS coordinator can gather PDPM data for all residents in the facility throughout the last year, and other nurse managers can gather history of special conditions and treatments being provided, the ADL needs of the residents by nursing managers and rehab services, special nutritional needs, and ethnic and cultural background. Next slide. So it's helpful to schedule a separate meeting ahead of the facility assessment to complete the hazard risk assessment with appropriate staff members and complete the infection control risk assessment with appropriate staff members. Next slide. So during the meeting, have team members contribute information prepared in advance. Discuss the diagnoses and special conditions you plan to care for in the coming year. It's helpful to break down the diagnoses into a list of categories, such as listed on this slide. Behavioral health, including active substance use disorder, dementia, Alzheimer's care, neoplasm, neuro, digestive, infectious diseases, etc. Next slide. Determine in your assessment which residents you can admit and that resources are available. Discuss how you care for residents with diagnoses or conditions not listed. You must document this discussion and include description of the process to make admission or continuing care for those diagnoses you are less familiar with. How do you determine if you can admit a person with a new diagnosis, and how you secure resources, including staff competency training? The MDS coordinator should come to the meeting with the QAD data from the previous year. This will help support the data-driven components of the requirement. List the number of residents with special treatments, such as cancer treatments, chemo, mental health, behavioral needs, respiratory, wound care, IVs, transfusion, and many others. Next slide. You would discuss the following general care areas, such as listed here as an example: ADLs, mobility and fall prevention, pain management, infection prevention and control, and other services provided. And remember to incorporate person-centered directed care. Next slide. So in the assessment, address what type of staff is needed to meet the needs of the resident. Data from the HR business office manager is helpful, or the person who completes the PBJ reporting. Outline staff needs through documentation of the facility organizational chart that includes all positions. Address the staffing plan based upon acuity. How did the team conclude on how many and what staff are needed? Include the total number needed or the average number needed for each position. Documentation of how the facility reviews individual staff assignment. Next slide. So you must consider staffing needs for each shift, as mentioned, addressing normal operations and emergencies. Determine what specific trainings and competencies necessary. Competency is defined as something measurable, a pattern of knowledge, skills, abilities, and behaviors. The policies and procedures needed to meet the facility population and identify the need for a new policy. List all health information technology services. Describe how the IPC program is evaluated. Develop, document, and maintain a plan to maximize recruitment and retention of direct care staff. And you must include to document contingency planning, how you manage callouts, the process for covering shifts, and the availability of supplies. Next slide. Well, with that, I'm turning it back to Mac.
Thank you so much, Charles. For any questions or concerns regarding this QSO effective on August 8th, 2024, please reach out to the contacts that you see on this slide. You can reach directly out to Charles at charles@hcn.org for guidance and clarification. And lastly, on this last slide are important links, including ACA NCAL's action brief, the ACA facility assessment checklist, as well as the QSO that was talked about in this training. Thank you guys so much for taking the time to join this training today. We appreciate it.
Thank you.